Hello, and welcome back to Nursing Life 101. We're so excited to have you here as we dive into the world of nursing, sharing experiences, insights, and a little bit of fun along the way. I'm Christopher.
And I'm Colby. Together, we're here to bring you real stories, practical tips, and conversations that remind us all why we love this wild world of nursing.
Today's episode is a special one. It's actually the first one we'll have in this entire series because we're not doing this alone.
Nope, we've got a guest in the house, a great colleague, friend, and a phenomenal provider.
Please welcome Daniel, physician assistant extraordinaire.
We're talking teamwork between nurses and APPs, sharing memorable cases, exploring how collaboration makes us all better.
So let's get into it, because this one's about respect, communication, and learning from each other. All right, Daniel, let's start with the basics. For our listeners who don't know you, who are you and what do you do?
I am a physician assistant, PA. I think the AAPA is trying to change the name to physician associate, which I think is kind of silly. But I'm a PA. I have worked at the same medical center as Christopher and Colby for about 7 years now. I started a little bit before Christopher, actually on the same unit as Christopher, and that's how we first met. That was in a vascular surgery step-down unit. Mm-hmm. I worked there for a couple years, and for the past few years, I've been working in limb preservation, which is a lot of diabetic foot infections, still some foot wounds due to vascular disease, and some trauma and ingrown toenails, and all sorts of fun stuff.
Do you remember like our first full conversation?
Was it on the bus?
Yeah.
I don't remember what we talked about, but I remember sitting on the bus and we started talking about something.
Yeah. And I'm trying to remember like why I was on the bus. Like I should not have been on the bus at the same time you did. Because like you left earlier than we did.
Oh, I feel like you were there for a meeting. I don't think you were. Yeah, I don't think you were. You had worked that day. I don't think you were in scrubs. I feel like you were wearing like street clothes.
Okay.
I was gonna say, what time of day was it?
Yeah, it was. It was like early,
probably
evening.
6.
Yeah.
5:36.
I guess it depends on what do you consider evening.
Yeah, like 4. Anything after 3 to like 6:30.
Okay.
After 6:30, it's nighttime. Actually, well, it depends on the time of year. When it's dark, it's night.
When it's dark, it's night.
That's, for me. So I could be 4:30 in December.
There's some early nights that we just came through.
The evening was short. It was 2 hours.
Afternoon doesn't exist.
Afternoon, who is she? Never met her.
Interesting. But yeah, I was wondering if you remembered on the bus. I don't remember our conversation either, but
I remember we talked about disc golf pretty early on, but I don't think it was that conversation. I think it was after that.
Broaching healthcare early on, going past it.
Yeah, we were like,
a real friendship.
Please, let's talk about something else.
Yeah.
we don't care about people that much.
Well, okay, so you guys have known each other a lot longer than I've known you, Daniel, but I feel like I've known of you for as long because you and then another one of our friends, Sarah, the three of you guys were pretty good friends, and I was always hearing about Daniel. And then I feel like there was a period of time where like we would pass each other in the hospital, and I think, at least I was thinking like, I think that's the Daniel that Christopher and Sarah are friends with. And you were probably doing the same thing, like, that could be the Colby. Not sure. And then the first time that I ever did anything with you, and we've talked about this before off mic, but when you were doing wound care on one of our LVAD patients, and I was holding the leg, and it was just the most gruesome, like horrific thing of like chunking flesh out with like this the craziest thing I've ever seen. This tool contraption that looks like kind of like a heavy duty toenail clipper. You were just like chunking flesh, and I was like, holy shit, this is crazy. And like, I will never forget that.
There have been a few nurses and like CNAs who I've been in a similar situation with, and there was one who I saw like a few months later after, and they're like, "Are you doing any more? I remember that last one. That foot was full of maggots. It was crazy." And I was like, "Not today, not that bad, but I'll let you know." Because they don't you don't forget that stuff.
I was just like holding this person's leg, and I was like, "Holy shit! I can't believe I'm not passing out right now." I was like fascinated and disgusted equally at the same time.
It's really helpful having another set of hands because these patients can really not do a lot for themselves.
Yeah.
And it's always awkward angles and trying to like do the job, and it's really tricky. So whenever someone's available, I'm like, can you
come hold
45 minutes to help me?
And it really can take that long.
Does lifting the bed actually help?
Oh yeah.
Yeah.
It helps your back.
I do it every time because if I don't, then I'm at a 90-degree angle. Okay. Even when I just like trim like a diabetic patient's toenails or something. I went 2 days ago, and there was a patient, and their big toenail was 1.5 inches just thick, like off of the nail bed.
What?
Whoa!
And it took. I mean, I was in that room for 30 minutes trimming toenails just because it took so much time. And if I didn't have the bed all the way up,
I have questions about the technique of that. Yeah. I don't know if I'm getting too far off the rails. Like, did you have to that's the thickness, did you come from the top as well?
She has three fingers on top of each other.
Stacked on top of each other.
Stacked on top of each other.
For our listeners.
Yeah.
Did you have to come from the top and the front?
You kind of have to take like bites off of the side.
Oh, you're
so
like
if
chunking
it's like a mountain peak, you kind of start from the top and then you go around the edge to work its way down, because there's no way you could just use like nail clippers and cut a piece
to
of it,
get through
it's so thick.
Keratin.
That is wild.
Yeah. Oof, I'm shook. And I just know that there was an odor.
Always.
Like, that's a given. That's a given. We're talking limb preservation. Okay, we got to get rid of this stuff to preserve. All right, let's get us back on track. So what pulled you toward medicine in the first place? Was there like a defining moment or like a story that brought you in?
I feel like a lot of people have had a family member or somebody that got sick, or they were sick and they got pulled in that way. I never had like a specific, now is the time I know I want to go into medicine, but I was always interested in medicine. I always thought it was cool. I remember watching, there was a TV show, it was Trauma, Life in the ER. And you know, they go through the ER and you see just people come in and there's blood everywhere. And I was just like, this is so cool. And my family was like, this is disgusting. Can we get this off the TV, please? And I always thought medicine was cool and interesting. And I liked a career that I felt like I was making a difference and not just trying to get a paycheck, but actually bringing something to society and helping people. Mm-hmm. I was interested in med school, but I wasn't all the way sold on it. And so I didn't want to commit to something like that without being 100%. And then I heard about PAs, physician assistants, and it seemed like a really good fit. It was a master's program, but you still got to do a lot of medicine and like work as part of a team, and that was right up my alley. And so I started working as a surgical tech in an outpatient skin cancer surgery center for a couple of years after undergrad, and that kind of solidified that I like medicine. I want to work in medicine, and then went to PA school from there.
Yeah. And you started in vascular.
Mm-hmm.
Did you kind of like know going into, like after graduating, going into the real world for a career that you were like, was vascular your thing? Was it a situation where you interviewed and that was one of the job offers that you got?
Oh, that's a good question.
Yeah. How did you land there first?
It wasn't my top choice initially. I'm glad I ended up there, but I really liked orthopedics. Mm-hmm. I liked the idea of, here's a problem, fix it, and it's fixed, and then it's done. And I like that. Exactly. Just, you've done it, you've fixed a problem, someone is better, and they go home and it's done. And you have like changed that person's life in a short period of time, rather than titrating blood pressure medications and things like that.
Yeah.
But there weren't, when I was looking for a job, there wasn't an opening that kind of fit. And I started looking into what was available, and one of them was vascular surgery. And the more I looked into it, the more I thought, this is actually really interesting. It's, it's vascular, so it's your arteries, it's blood flow, which is every part of the body. Mm-hmm. So you get lots of experience. They're usually pretty sick people with lots of comorbidities. So there are lots of different facets of medicine that you kind of dip your toe into. And it's surgery, which I was always interested in. So you still get that element of it. So not something I was immediately drawn to, but once I learned about it and looked into it and, applied and interviewed to it, I was really interested in it. And I still have kind of an aspect of that in my current job, which I still like.
Yeah, I was going to say it was kind of almost like a natural transition into what you're doing now with the limb preservation. And that also kind of got you to your ortho dream, quote unquote. So it's kind of cool. It gave you a good basis. And I feel it's not to compare it to med surg nursing, 'cause obviously two very different things, but you get a wider amount is not the word I'm looking for. I'm just having trouble finding words right now. But you get a larger knowledge base, and then you can take that and build off. You have all this background knowledge extensively because that's your specialty for a while, and it goes hand in hand with limb preservation. I mean, a lot of the reason why limbs need to be preserved is because there's poor vascularization. So. Mm-hmm. Yeah,
exactly. That was part of the reason I took the job. The podiatrist that I work with, I also really like her, and she has been here for a few years, and that was part of it. But it was an easy kind of tangential transition. So it wasn't something where I'm starting over fresh. It was a lot of similar patients, similar stuff that we're doing, just kind of a different aspect of it. So it was kind of an easy switch, which I was also interested in.
And so I guess this is a question I don't think I've actually asked you. Well, in terms of physician assistants and APPs in general, when you started, vascular was an MU floor. Is there for nursing, you had to learn that you become an acute care nurse or an MU nurse or an ICU nurse? Is there varying degrees of acuity in terms of when you're learning? Does it really matter?
Oh, yeah, that's a good question, because even nurse practitioners, you can do family medicine or you can do acute and be in the hospital versus a clinic.
A clinic, yeah.
For PAs, there's not a delineation. Mm-hmm. It's you're trained, and once you graduate and pass your boards, mm-hmm. you're qualified to do kind of anything and everything. Mm-hmm. So we can work in the operating room as a first assist, which can be up to quite a bit depending on the surgeon and their level of comfort. You can work in the ICU. You can work with kids. You can work on the floor. You can work outpatient. There's really anything. And when I first started this job on the acute and intermediate, I didn't really know what an intermediate unit was.
Right.
I had very little experience in a hospital mm-hmm. before my first job, and so I was kind of learning. And I remember asking, what is the difference? What patients are MU or intermediate versus just the acute care? What do I need to know?
Yeah.
Took some time for me to figure that part out.
Well, interesting enough, it depends on the health system too.
Yeah.
Because our health system has a certain guideline, or what is the do you remember on our little
it's just levels of care?
Yeah.
Yeah. But yeah, which is a guideline on how to determine if someone is MU status. And as far as our health system goes, it's pretty cushy. And some people who have never worked other hospitals may have an argument for the opposite of that, but there's a lot of hospitals that I worked at multiple hospitals. So there's a few hospitals I worked at where their guideline is much more strict, and so you could have a very heavy acute care mm-hmm. assignment, where at our facility it would be considered an MU assignment and you wouldn't have had that many patients. Mm-hmm. But I've also worked at another hospital who's even more cushy.
Really?
Yeah. There's a hospital system I worked for when I was traveling, and they had a PCCU, which is a progressive coronary care unit, and it was all post-cath, post-pacemaker, but it was just post those procedures. But they were this is a very serious MU, and you can't have more than 3 patients. I'm these are the easiest patients that I get in my home hospital. This is a joke, right? And so I would love when I got floated to that floor, because I knew I'd be kicked back.
Right.
This is nothing. I'd be all right, cool.
Sounds like a nice unit.
Yeah.
Well, it is interesting to kind of hear about your start to medicine. I'm curious, outside the hospital? What keeps you busy? Any hobbies or any random skills we would like to know about?
I don't know about random skills,
Okay.
but hobbies. As you know, I like to play pickleball.
You're right.
Christopher and I play pickleball quite a bit together.
We have 2 leagues.
Yeah, they have a championship ring.
We don't have one.
Oh, I have never seen the other one.
Oh, okay. I'll show you the second one as I dig into my book bag.
I like pretty basic stuff. I don't know, I sort of consider myself a foodie. I like to try new foods. I'm always, like to eat and go out to restaurants. I like sports. I'm into football. I like games in general, video games, card games, sport games, anything you can win at. I like to play them.
Yeah, I realized Daniel is actually is probably my equal in terms of competitiveness.
I was just going to say that.
Yeah, and it shows because he's been beating me at pickleball recently, and it's been so sad.
That is, I think the ground just shook.
It did.
Was there an earthquake?
We're pretty comparable. They're pretty close games. It goes back and forth.
Yeah,
I'm sure, and that's also why in doubles you guys smash in every league that you're in, literally. Lordy. Well, okay, I have to ask, what were your first thoughts when you heard about Nursing Life 101? When Christopher was like, listen to our podcast.
I think I heard about this podcast years ago. I think Christopher talked about it early on and kind of threw it out there. And it sounded like a great idea. But once it really got going, I started listening to it right away. And I've really enjoyed it. I know it's geared towards nursing, and I've never been a nurse, but I think it's pretty relatable to all of healthcare and working in a hospital and working in the healthcare field with, there's lots of different aspects there. And I feel like it's interesting, and you guys dig deep, and I feel like you guys are, have good banter back and forth. So I like it. It's a good podcast. My wife started listening to it as well. She's not in the medical field.
Oh, really?
At
I didn't know she did. Really?
Yeah.
Oh, that's cool.
That's awesome.
She hates medical field.
That's how much she likes you, Christopher, and me. We've only met once. But...
I do appreciate that, actually, a lot. A lot. Roman says hello.
Shout out to Mickey. Which is funny because also that's my sister's name, so it's like a double shout out.
Yeah, it is pretty cool.
Oh goodness,
that's funny. Yeah, I mean, and we'll talk about this like later on in terms of like future stuff. But what has been your like favorite episode so far, and then like what could we improve on?
Ooh,
that's a good question.
I'm excited to hear this though. Actually, I like feedback.
I don't know if I could list off a favorite. I feel like I've listened to them all, and it's hard for me to specifically say which one was which. I think the like work relationship romance one I liked. I just felt like it was kind of funny. And
Are you saying that just because of our conversation today? Okay.
I'm not. That's just the one that jumps out. I feel like you guys had good banter, and it was like a fun little back and forth.
Yeah, that one I definitely had the giggles throughout. I can't imagine how much you had to edit out of that one.
Well, and it's funny because like there's so much more that I would like to say in that like realm that I just probably can't.
We could always go back and make another.
Oh, well, we'll think about it.
I don't have a lot to bring to the table for that one.
Well, I know. Yeah. And I'm the only one that's probably been borderline. Well, not borderline. I've been in relationships with people.
I do think it was really funny, the burnout episode.
Oh.
Because that was 90% Colby and Christopher.
That was just my episode.
Had nothing to add. Not that I think it was better without Christopher, but I just thought it was funny that it was just not a lot you could could weigh in on.
I couldn't.
You're like, burnout, never heard of her. Yeah, I was like, burnout, me and burnout are best friends. I can tell you a lot about that.
Yeah. Okay, so what could we improve on?
That's a good question.
I mean, I know I asked it now.
Not to put you on the spot.
No
or
notes.
anything.
No. I can't think of anything that you actually like. I would say you need to improve on. I think just continuing to expand what your each episode is about. Like, I think this is a fun episode. I mean, obviously I'm here, so it's biased, but I think, including guests, and I think you had mentioned potentially doing another guest in the future. And I think that'll be cool. And just kind of continuing to get into kind of more niche topics of healthcare. I feel like healthcare is so broad, and trying to pinpoint on kind of little specific things you can get into.
Yeah, I think that's good advice.
Well, ultimately, I just want to say, we promise we didn't pay Daniel to say any of this.
Not yet.
Yeah, I'm not opposed to being paid.
You're like, wait a minute, I could get paid?
I mean, technically I paid for the food. You just Venmo'd me.
You can reject that.
Yeah, I could.
Oh my gosh.
Just send it back to you.
You're like, and that's done. All right, it's time for Spotlight Case, where we dive into real-life patient story that sticks with us.
These are the cases that test your judgment, your teamwork, and sometimes your emotional limits.
So, Daniel, you've seen a lot of medicine in action. Do you have a case that changed your practice or how you see patient care?
I think it's hard to narrow down a specific case, but just as my time, especially for the first few months of working in a hospital and seeing these, more acute patients, just seeing what these people have to go through and what it takes as, the whole hospital system, from the surgeons, the doctors, the residents, the fellows, the APPs, the nurses, everyone all together. And it's everyone's job. And I think it's easy to just kind of come in, do what you have to do and clock out. But when you can kind of look at it as this is the worst experience in this person's life. Mm-hmm. They're having the worst time, and just being able to spend a little extra time with the patient. I feel like there were a lot of times when I'd round with the surgeons and they'd come in for a second. How you doing this morning? They're still asleep. They're not even able, they're not even answering.
Their eye cracked.
They're like, okay, yep, everything looks good to you. And then you come back in and you're like, so did you catch everything they said? And they're like, no. Mm-hmm. And so then I'd sit there and, spend 15, 20, 30 minutes and kind of talk it through with them and explain everything going on, explain the next steps, and just being able to give the time that the patients really need to help understand what's going on and kind of help them feel better in the situation when, they're terrified. They don't know what's happening. Mm-hmm. It's a horrible situation. And I think just being able to slow things down and try to look at it from their perspective, it's stuff that we come in and do all the time. Mm-hmm. So we do a lot of amputations and major amputations where we're cutting off someone's leg and it's completely changing their life.
Right.
And we do it all the time. And so it can become a little bit kind of like benign to look at from our perspective, but it's completely life-changing for these people. And so I always try to, take a second before I go in the room and be like, this is going to change their life. Let me make sure I'm approaching it in the right state of mind to be able to see it from their perspective and try to spend the time and talk them through it and work with them.
Yeah, that's so true from almost anything that we do as healthcare workers, especially in the hospital settings. If you're in the hospital, you're sick as shit. And that, on all levels, it could be something we see every single day and we're like, okay, whatever. But it, like you said, it's life-changing for that person. It could be their worst day that they've ever had. And just because it's our normal, we have to remember and keep ourselves in check that it's not their normal by any means.
For sure. And, you mentioned earlier, Colby, about, holding the leg of a person so that, and Daniel, you were like, yeah, it's nice to have somebody to hold a leg for 45 minutes. What's been the longest you've had somebody hold a leg? Do you know?
There was a patient, probably the one that I mentioned, where this lady came in and she came in from a facility and she was just getting really poor care and she had just her foot basically full of maggots. Oh. It was pretty bad.
From a facility, not even from home.
It was unfortunate. And it was something where I'm like, I need help.
Yeah.
And so there was, I think it was one of the CNAs, and she came in and she helped me. It was over an hour. And as I'm sitting there doing it, the assistant nurse manager on the unit came in and, saw what was going on and went back and like brought her the little like coffee gift card and like put it in her scrub pocket.
You deserved it.
Yeah. And I was like, can you give her more than one, please? What do I need to do to like write her a positive accommodation? I don't know.
I mean, you could have gave her
a B nomination.
A B nomination, yeah.
It's just like
I don't know what that is.
Okay, sidebar. Like how the Daisy is for nurses, the B is for like any ancillary staff, so our CNAs, but even like facility like maintenance guy could get, which I also wrote one for one of them, can get a B award. Yeah. It's the same QR code. So if you walk by any of the Daisy stuff, you take the QR code in the future, just in case.
Good to know.
All right, back on track.
It's unfortunate for that person that you didn't know.
Yeah, whoever you were, you were this close to a B nomination.
Great job.
Oh, well, while we're on this sidetrack, is the B nomination just our healthcare facility?
I don't think it is. I
think it goes with Daisy? Because Daisy's like, it could be nationwide. Mm-hmm. Okay, cool.
But to that, is there anything that's similar to the Daisy for APPs?
Oh, yeah.
I think that nurse practitioners are still eligible for the Daisy.
Okay. Yeah.
And PAs are not.
You can get a B.
Really? That's
why not?
Come on now.
Who says it can't? It's not.
That sucks that they can't get a Daisy though.
I was technically nominated in a group once for a Daisy, which I didn't really think made sense because I'm not a nurse or in the nursing umbrella in any capacity. But the group that I was working with was nominated as a group.
Oh, okay.
Nominated, did not receive.
That's okay. I've only been nominated once. We talked about that in the first season. Wait, Christopher, have you ever been nominated? I don't know that we ever talked about you. We only talked about me.
I've been nominated.
Once? Twice?
I'm trying to think.
He's like more than once,
It's been more than once. I want to say 3 times.
Oh, of course.
I've never won. I've been nominated, though.
How does the nomination versus receiving work? Is it a group gets nominated, only one person of that for that time period? Or?
Yeah, and I think they do it monthly.
Monthly, okay.
Mm-hmm. And there's a committee of people who like read all the stories, and like all of like the names and units that they work on are blacked out, and then they put in their votes for who should win.
Do you get anything? Is it just a little pin?
Well, you get the Daisy pin for being nominated, but if you win, you get a marble statue that's about maybe 7 inches
It's marble?
high.
I thought it was...
Well, it's like a rock.
Oh, I thought it was glass. Okay.
Well, the B is a glass.
Oh, got it.
But the Daisy is like this, like, it's like this statue of like, I feel like it looks like abstract emoji with arms, kind of arms out encompassing another emoji avatar. Google it. I'm probably not describing the right thing.
I'm sitting here watching you describe it with your body.
Well, let me get you a picture. Please hold.
Okay.
Daisy?
Well, we're waiting. So PAs don't actually have one?
Tell me I'm wrong, though.
Oh, okay,
yeah. Well, if you Googled at this point, if you weren't driving, what I was describing was exactly what you're seeing if it's not the pin and it's the marble rock statue with the arms out.
I didn't know. Yeah, man, that's wild. I would have never guessed that.
Yep.
I've never seen that before.
Me neither.
There's a team pin. Wait, so this might have been what you could have gotten for a winner, I guess?
Oh.
It's like a group of daisies. There's a nurse leader one. That could be me or you.
No, I'm not getting one anytime soon.
And then there's the nominee one. And then whatever an honoree pin is, maybe that's what the B was at some point.
Honoree.
An honoree? Whatever.
You know, we might actually need to look to see if the B is a national thing.
I think it is, because this is a different health system.
There we go.
There we go.
That's also talking about the
Good to know.
Which makes sense. It goes, like
the bee goes on a daisy.
Daisies.
Yeah.
Yeah.
Oh.
Yeah.
Did not make that connection.
Okay, but then also this Etsy pin, it's wilted daisy.
Oh no.
And that would be hilarious. Okay.
I'm gonna get those for you, both of you.
I would wear it.
We are tapped out.
Just a burnt out daisy.
What point of your career, you were saying 7 years, has been like a moment where you're like, man, this has been really challenging or really rough?
During COVID, I feel like there were some tough times. I think I'd been working for about a year, so I felt like I had kind of just gotten on my feet.
Mm-hmm.
And then as COVID was ramping up in the US, but in our area specifically,
Mm-hmm.
they combined the unit that we were working on, from vascular to include cardiac, thoracic surgery, and vascular surgery.
Right.
So they merged all those together. So it was 2 new service lines, a bunch of new surgeons, all new staff that we were learning, in addition to the COVID epidemic and having to deal with all of that.
Well, and that's when you moved too. Like you moved from our unit to a different unit to have that.
Right, when I was getting used to all of the nurses, all of the staff, starting to really get relationships with everyone, and then it was, here's a brand new group of people.
I guess I didn't really think about it, but yeah, when they did that, like Christopher, who worked on that unit, like it's funny, the staff came to the medicine side of cards, or I guess you guys had a choice. Some of
we had a choice, but everybody stayed.
Yeah, so everybody ended up coming to my unit, which was like acute cards, which is like a step down from our CCU. But yeah, then our vascular went with TCV, with the thoracic cardiovascular. Yeah.
We all moved units, and the nurses the whole nursing unit there were all vascular surgery nurses. Not one of them went with the patients. Join TCV. They all went to cards, or a few of them I think went to other random units, but none of them moved with us.
No. Which was wild. But was that the challenging part? Was it like, what made it challenging then?
I think all of the aspects of it.
Okay.
COVID in itself was hard. I feel like it wasn't as busy because we stopped doing a lot of surgery because, and those were our main patient populations. But they told us that if things got really bad, then we would have to just start taking care of COVID patients as the primary team without having, any real experience doing it. Mm-hmm. We had to go onto COVID units. We were doing a lot of chest tubes. And so, having to have someone watch you don and doff to go into COVID units and do that. So all of that going on with the, kind of the scariness of the US during that time and not really knowing what was happening and, knowing people that got really sick and all of that and what the future looked like post-COVID. And then kind of at a, more microscopic level, changing units, having to readjust and do that. When I started the job, they said, you won't have to change, or we're not going to combine these. And I said, that sounds great. And then a year later, they're like, we're combining them.
Yeah, they're like, just kidding.
Here we go.
We pulled a fast one on you. Mm-hmm. Yeah, all of that layered on top of each other, and you're just barely out of the year mark of like just feeling comfortable and being like, all right, I think I know what I'm doing out here now. Like I feel more confident.
Exactly.
And then it's like, just kidding, we're gonna pull the rug out from underneath you and you're gonna start over. Mm-hmm. That's a nightmare. That's a nightmare for sure.
It was a little rough there for a while.
I guess that's a great segue into the next question that we had was like, what did you learn from that experience that you still carry today?
I think a little cheesy, but the teamwork aspect of it, like leaning on the other providers, the people that I work with that moved with me, and then the new APPs that were already on that unit that I could really rely on and learn from. And some of them had quite a bit of experience, and they're really good resources. And then trying to kind of quickly find the nurses that were the more senior nurses that, I'd have a question, I could just ask them like, what's going on with this chest tube? Can you walk me through this? And so just really relying on resources, but just of everyone from, the surgeons, the fellows, the nurses, the residents. There were a few CNAs who I still, when if they came into the room and said, you need to see this patient, I was up and out of the door in a second. Cause I'm like, this person knows what's up, and they can tell when something's going down. So
yeah, for sure,
trust your staff.
Yeah
I mean, I would say that's a powerful takeaway. Those moments really remind us that medicine is more than tasks or orders.
Right. It's about how we show up for patients and for each other.
Yep. And that wraps up this week's Spotlight case, a reminder that every patient teaches us something, even when we don't realize it in the moment.
Exactly. Those lessons shape who we are, the challenges, the teamwork, and sometimes even the failures.
All right. Let's talk about something that's both real and sometimes tricky, the dynamics between RNs and APPs.
Yeah, because teamwork between nurses and providers can either make a shift fly by or make it feel like a 24-hour marathon.
So, Daniel, from your perspective, what do you think makes nurse to APP relationships work well?
I think communication is key, but I also think it's the specific communication. There were definitely some nurses that I used to work with that were over communicators.
Okay. I love how you're looking at me. I feel like it's me.
It's not you.
Okay.
Just page after page with borderline normal vitals that we're not going to do anything about.
Right.
Questions about, is it okay to hold the Miralax? The patient has had 3 bowel movements today. Yep, it's okay. You can say the patient refused it and not give it. It's fine. I was always a fan of the communication. We had our workroom on the unit, and so the kind of the culture was nurses would just pop in and ask us a question, which I liked. I liked the kind of instant gratification of ask a question, here's an answer. But I know some of the ABVs and some of the residents got really frustrated with the constant bombardment of like, why are these nurses coming in here all the time asking us questions? Can they just send me a page? I liked the open communication, and I was pretty close with most of the nurses at the time.
Yeah.
But sometimes it would be a little much.
I think that's huge for me. Communication is everything personally. I like to know the why behind why we're doing something. And so sometimes I definitely am not that person who's like, the blood pressure was 128/70. Should we hold that medication? And you're like, no, the blood pressure is normal. And it's normal because they got the medication. They need to continue to have it. I agree with you. When I see nurses with years of experience, nurse with 1 day of experience, when I hear them ask questions like that, I want to like bop them on the back of the head and be like, use your brain. Like, come on. This is like when you're getting a report from the ED and I hear a nurse say, well, what's their skin look like? I'm like, are you kidding me right now? That ED nurse doesn't even know. They have no freaking clue what the back side of that patient looks like. They hardly even know what the front side looks like. Get the patient upstairs so we can get them safe. Anyways, but tangential.
I always thought it was funny that I feel like the APPs that gave the nurses the hardest time were the nurse practitioners. There was one NP that I worked with who had been a nurse for 20 years. She worked in the SICU. And if a nurse asked her like a quote unquote dumb question, she would be like, you shouldn't be asking that question. You should be able to figure that out. You should talk to your colleagues. You should talk to your charge nurse. This is not a question that you need to ask a provider. And I was like, that's a little rough, but
you're like, but yeah, that's what I wanted
wrong.
to say. That's exactly what I wanted to say. Even as a more not more qualified, but like more seasoned nurse on the floor, I also share those. When I like hear these things, I'm like, why didn't you just ask me? Like, why didn't you ask anybody else? Because we all probably would have told you. They don't care.
They cannot.
That's like another example of that is in the cards world when someone's in AFib, like it can ring for a pause frequently, but unless it's greater than 3-second pause when someone's in AFib, the providers don't care at all because it's not like a true pause. It's just they're in AFib. And the monitor room will call us incessantly and being like, the patient had a 2.8 seconds pause. The patient had a 2.3 second pause. And I will literally tell them, like, do not call unless it's greater than 3 seconds. But some nurses will page the doctors incessantly and they don't respond, which makes them page them more. It's insane. It's like, okay, can we just all talk about this for a minute?
Yeah. And that's almost why I'd rather just you come in and say it. And so I can be like, that's fine.
Yeah.
This patient's done that 100 times in the past 48 hours. We're good.
Yeah.
It's okay.
We're okay.
You can ignore it. Let me know if it's 8 seconds.
Yeah.
Well, that actually brings a question. There was at one point, and this is this is not to do anything with RN to PA or APP interaction. There was one point we were playing pickleball and you said you wanted to say something about some episode.
He's like,
do you remember what this was? I feel like it was something cardiac related. Wasn't it EKG related?
I'm trying to remember. I think it was somebody had,
was it EKG and they had EKG? Like it was already done.
I have to go back and listen to the episode. I remember the situation, but I can't remember the specific details.
Yeah. Okay, it was something EKG related.
Oh, something that we had already talked about?
You guys had mentioned that they wanted an EKG for something and it seemed pointless or like it wasn't going to change management. And in my mind, I was like, well, it could change management for XYZ reasons. And Christopher's like, you should have just commented on it and told us. And I was like, I didn't. I just told him later.
These things, listeners, is the reason why we have an open communication for you to contact us and tell us that we're wrong. We're okay with being told we're wrong.
Yeah.
We would love to hear we're wrong, just to allow wonderful communication and
learning opportunity.
Yeah.
No, now it's going to bother me. I'm going to listen to every episode until I figure out which one it was and be like, okay, Daniel, I found it. Teach me what was wrong, like what we were missing.
I wanted, man, but I think it was because we were saying like EKGs were expensive.
Oh, yeah. Maybe.
Was it like someone had a run of VTAC and then maybe you see it on telemetry?
Yeah.
And then
but we couldn't capture it and they were already back in normal sinus. And I'm like, why are we going to get another EKG if they're already back in normal sinus?
Right. Okay. I think that was it.
Okay.
My explanation was that, or my reasoning and reason I would want one if it was something new. If they'd done it a bunch of times, that's one thing. But if they had an acute event that initiated the VTAC or whatever it was, you could see those changes on an EKG if you compare it to like an old EKG and now they had flip T waves, or if they had some ST elevation or something that's changed post the VTAC incident.
If like all of a sudden now there's
a difference.
ST changes. I
agree. You're not going to catch the VTAC right after you saw it. You're like, oh, let's do it 8 minutes later and see if we catch it. But there still could be a reason to.
See, I'm so glad that you said that because that makes a lot of sense. But that's like in my brain, I'm just like, we're not going to catch the VTAC run.
Right.
Yeah, but that. Now I love to know the why. I love to have the communication. And literally no resident has ever explained that. They're just like, get another EKG. I'm like, why? And they're like, they probably don't even know why, to be honest.
Some of them I'm sure do. Some of them might not.
They're like, I think they just tell us to do these things. And then it gets trickled down to the nurse. And then here I am. I'm like, why? I'm like, all right, I'll freaking do it, I guess.
I have seen that before where I feel like, especially July interns, their first time being a doctor and, their upper level or the attending tells them to do something. And then so they have the nurse do it and the nurses ask and they're like, I don't know. They told me to do it. So I put the order in and now you have to do it.
Oh, yeah, definitely. That is very true. Oh, wow. Okay, I also kind of feel stupid now that you're like, no, maybe there's some changes that we were looking for that caused the VTAC run. Like, duh, of course.
But I think, 99 times out of 100, you're going to do it, and it's going to be the same EKG that one you got the day before and the day before. And you're not going to see changes. But just in case.
One time is enough that warrant the EKG. That makes sense. What's really cool is we're getting these new EKG machines that will hopefully be rolled out starting next month in March.
Is it just inpatient or everybody?
The whole health system, but they're rolling it out in
phases.
Yeah. So like heart and vascular obviously will be like the first areas to get it. And I don't know if they're going to do inpatient, which would make sense to do like the cath lab, the EP, like they would get them first and then the floors and then outpatient. So, but hopefully in the next month they can start rolling them out. But I got to play with it last year when GE came to kind of show it to us. Did you get to go?
No, you had asked if I could go and I wasn't able to.
Oh, did you get to play with them? No.
I didn't even know this happening.
They're sick. Like the technology on them, like we could probably capture VTAC. Like we can hook them up and like it's very cool. It can like run continuously without printing continuously, and then it's able to like self-detect when something is awry, and then it'll like print itself.
That's neat.
Yeah, so if someone's like going in and out of it kind of frequently, you can just leave them hooked up to it for a few minutes, and it'll capture it. And then you can go back and look at like a full disclosure and like grab it, which is awesome.
I've seen some patients where they just keep printing, and it's just a 1-inch stack of EKG strips because they just keep printing and printing, trying to catch something.
Well, yeah, you can do like a run.
You can,
you can like make it run. Yeah.
But then at like what point is it like different from just being on telemetry?
Yeah.
It's like not really.
Not really.
Yeah. So we have that to look forward to. Nicer,
exciting stuff.
Exciting things. Yeah.
That is neat.
Yeah, I think it has barcode. I'm pretty sure, if I remember correctly, it's a barcode scanner too. So you just scan
the band,
patient's band, and all the information goes in there, and it'll marry it to the order.
That's neat.
Yeah.
You don't really care about that part, though, do you?
Well, with my position now, I haven't looked at EKGs in a couple of years, but when I was working on the inpatient unit all the time, and then the strip wouldn't save and get uploaded into the electronic medical record.
Get lost in the cloud.
It would be, and I was like, why? And they're like, can you go back and get it? And they're like, we can try and see. And it's like, well, we wanted to see it. If we can't save it, why did we do it?
Yeah.
So hopefully that will make that much better.
It should, yeah.
Oh my goodness.
What's something you've always wanted to ask a nurse, but maybe never said it out loud?
Ooh, this is a good question.
I've been pretty close with a lot of nurses I've worked with, and obviously I've known Chris. So if it's something, I probably would have asked him at some point. But I can throw a couple examples out. There's this one.
Well, you didn't know about the B.
Tell me about B.
What's the B award?
There was a nurse one time who, about 2 a.m. on a night shift, sent a page that said, the patient's advance directive was not up to date. Will you come and talk with them about it?
2 a.m.
And this is 2 in the
2
morning.
o'clock in the morning?
And I just couldn't understand why.
Were they like close to death?
No. They were fine. They were going to discharge home in a day or 2.
What?
And I really could not understand why they were doing it. But as a more general question, I get night shifts are a little bit slower and you have more time.
Yeah.
But digging into all of these orders and trying to, clean up the orders and go through everything and then bring them to the provider who's covering all of the patients and doesn't really know all of them in great detail.
Right.
And then asking, will you go through all of their orders and discontinue everything and make the adjustments? And it was kind of like, why are we doing this now? Why are we doing this at 2 a.m?
Yeah. I mean, I think there's an importance because aren't they charged for like per order?
Yeah.
So like,
are they charged per order?
I don't know for sure, but I know that's part of charge capture, like is the orders that are put in. Order. But I know that there's also they kind of like do like a lump sum of like, it'll say like nursing care and it'll list like a bunch of stuff. So I'm not exactly sure how it looks on the bill. But I would say it happens at 2 o'clock in the morning, like you said, because we have a lot of time. And like that's when we're like looking at orders. And like I would say like after 8 years of working night shift, I would look at it, and this was before we had like what's it called? It's like save, where you like do it and you
like
just leave
pen
it.
Them for
pen them. Yes, exactly. So it was before we had pending orders as floor nurses. So I would go through and I'd be like, this patient was in the CCU for 24 hours and then came out to the floor. They've been out on the floor for 6 days now and they still have ICU orders and acute care orders. Like, can we just clean this up? Like, clean it up.
Okay, that's fair. That makes sense.
Yeah. So like but like to ask somebody to come to the bedside at 2 a.m. to talk about it in advanced care. Like, this is another thing that I would like want to smack somebody in the back of the head for. Like, use your brain. Come on.
Yeah,
like,
what were they thinking? Like,
yeah.
I can't even.
I don't know.
Another thing people do is like ask for like bowel management, like medications at 2 o'clock in the morning when the patient's asleep, and it's not like, just tell day shift in your report on the way out and get it like they can have it in the morning. We're not going to wake the patient up at 2 o'clock in the morning for
a suppository up their butt.
Yeah. I mean, not like unless the patient's in pain, awake, saying, I really got to have a bowel movement. Like, I'm so uncomfortable. Like, let them sleep. let them poop in the morning. Like, why are we paging about this?
Totally agree.
Yeah, cosign.
Let them sleep, decrease their chance of delirium, decrease their chance of prolonged hospital stay. Yes. Let them sleep.
Exactly.
Yeah. During night shift, because you also did both shifts too. So, like, what do you have any for the APP colleagues that are listening? Do you have any tips, tricks on staying up at night?
It was the way that my unit did it, I think was less than ideal, because it was usually one week a month, and it would be 3 12-hour shifts. Yeah. And so it would be 3 night shifts and then back to days. And at one point we were short staffed, and it ended up being like 2 weeks per month, but it would be split up. So it would be like
every other
or something like that. Like, I would always try to lump them all together and just do 6 or 7 in a row or something and just do them all, but not always worked. And the back and forth was really hard. And that was I didn't mind night shift, but I did not like the trying to switch back and forth. Yeah. And I think you guys have said before, they have like 6-week blocks, which I wouldn't have loved to be on nights for 6 weeks straight, but at least you can kind of have a more formalized schedule.
That's what I did.
That's what Christopher does.
Everybody does that.
Oh, really?
Yeah, but not every unit does that. So like Cards doesn't do that. You have like if you're hired as a rotator, you have 2 weeks required of working night shift, and you can do it however you want. And some floors do it like that as well. And my previous unit, if you weren't very clear with your boundaries, they could put you on night shift, day shift, night shift in the same week. Like, it's really unhealthy. It's really crappy that they do it like that. But it's like also like if you're not clear with your boundaries, that's going to happen to you. I was very clear with my boundaries. I did try to rotate for a little while when I came back after I was done traveling, and I was doing the inpatient charge role, but as like a hybrid half day, half night. And it was basically just covering like PTOs. And I wanted to die. I think I did it from May until September, and then I had a mental breakdown one morning after a night shift. And I was like, I can't do this anymore. And they were like, okay, well, it's your lucky day because somebody's going they're like transitioning into being an NP in 2 more weeks, and you can have their spot. And I was like, thank God. So I think I did it for like 5 months, and it broke me down, being a rotator like that.
I remember when you would just pop over from the unit and hop over to like my unit, and you'd be like, yeah, just trying to stay away.
And I think I was lucky. I know some people say they're, a black cloud or whatever. And I had some colleagues who said every time they were on night shift, somebody would code, somebody would have problems, people would get escalated to the ICU. And I had like months, a year, where all of my night shifts were pretty quiet. A couple little things here and there, but very, very little. And so, things could always happen. And so we were always like ready, and little stuff did, but it really was pretty chill most of the time.
Very lucky. I'm going to knock on wood.
Yeah, sorry. Yeah. The Q word.
The Q word. Oh, I'm going to jump into the superstitions really quick. Is there any? I have that question, and then I have another one. Like, I have all these questions popping up in my head now.
Ask away.
Do you have like a medical superstition that you like? It is your superstition. Like you can't say the Q word or.
No.
Oh, are you a non-believer?
I always thought it was so dumb when nurses would get freaked out when people would say, I'd come over to your unit and I'd say, wow, it's really quiet over here. And then all the nurses would look over at me and get rid
Christopher's flipping a table.
There was one, I think she was a case manager, who said that there was a ghost on one of the units or on one of the rooms on our unit.
Yeah.
There was like a picture that somebody took, and you could see them.
Oh, I've seen the picture.
Have you seen the picture?
Oh, yeah. In Fort West.
Mm-hmm.
Oh, yeah.
Mm-hmm.
Did you say them? Oh, yeah, I guess it doesn't matter what unit it is. Yeah.
Yeah. That was the unit. The picture's still floating around.
I've seen it.
Wow.
No, I'm not a very superstitious person. In general.
So there was somebody else that was not a superstitious person, and they said it's quiet around here. And literally the bathroom like emergency was pulled at the clinic, and they turned red because they were like, I just said, and I was like, this is why you don't say it.
This is your fault.
Now they're just a little stitches.
Yeah, they're not super. They're just stitches. That's funny. My other question is, you worked closely with attendings.
Mm-hmm.
What's something nurses did that pissed off an attending?
Probably the biggest one, at least in that unit, was the eyes and nose.
Oh, see, that it's important, y'all.
Yeah.
They were, a lot of these patients had cardiac surgery, open heart surgery, and their volume status was a little tenuous, and they would be getting dosed diuretics, Lasix, Bumex, something every day, and the weights were always questionable because they were bed weights 50% of the time and would be up 6 kilos from the day before, and you're like, I don't know if that's right. And so it would be a lot of just trying to measure eyes and nose, and it was always hard to get. And I remember coming on in the morning I'd look and they wouldn't be up to date, and I would just send like 4 or 5 pages in a row just so that I could try to have that information by the time we rounded with the fellows and the attendings, just because I knew it wasn't going to be documented and it wasn't going to be on our printout, our little handoff, just because it was not there. So I feel like getting patients up, which I know it takes a village. It's not just the nurses, so I don't want to blame it on nurses, because it's PT, and it's the techs, and it's the family, and it's the patient who's refusing, and even the APPs and residents can go in there and do it and can encourage people. So I understand it's not just the nurses, but I feel like it's easy to just say, yeah, those nurses really slack. So anything that they not getting up, not documenting.
I feel like that's a very real list, though. And I feel like that's exactly like what you hear from management, like the ask, like, make sure everyone's doing, as a charge nurse, like, make sure everybody's getting their eyes and nose in. Make sure you talk about that at huddle. Make sure you talk about at huddle that we need to get people up on standing scales. Night shift cannot be doing bed weights. Make sure, like, it's like everything you just listed. I'm like, yep, check. Yes.
Which is wild. But I mean, it makes people upset.
Yeah.
I mean, but
it makes sense.
It's medical. It's medically relevant for it to happen.
Yeah.
So I get it.
Especially on my old unit, being acute cards was heavily heart failure. Yeah. And those are like the 2 main things. Like, these patients are here to get IV diuresed. These are the 2 main things that we use in order to decide dosing and, outside of lab work. And we still can't get it right.
Well, I mean, and then for you, and then for transplant, we had the kidneys. We needed to make sure, are we going to need to do dialysis? Or are we not? Like, yes, we have labs to see all these things, but are they volume overloaded? Like, what is it? What is going on? So,
yeah. And it's not just because they want to know. It's because it makes real decisions, and it affects the real decisions and the medical management of these patients, which can do a lot. If you over diurese them, and they can have kidney damage and they can have kidney failure, and they just had this, and so you really have to toe the line. And when you don't have that information, you can't go back and get it. No. It's literally flushed down the toilet. It's gone.
True.
Man.
Well, I think a lot of us nurses forget that, while we have a lot of pressure, so do our APP colleagues. They have an insane amount of pressure on them too. So it's refreshing to hear and remember and get reminded that it does go both ways.
Yeah, it really does. So I asked you earlier about, anything that we could do to improve or to change in terms of Nursing Life 101. And you had mentioned exploring more deeply in terms of the niche aspects of medicine. But then Colby asked you a question.
Topics?
Oh, yeah, about topics. So
did you think of
about that?
You'd like us to cover?
Yeah. Just to kind of lean into the guest aspect, and it doesn't have to be, but I think maybe picking specific aspects of nursing or healthcare. So I work in the operating room sometimes now, and I feel like OR nursing is quite different from outpatient, inpatient nursing.
Mhm.
So, and I think neither of you have experience in the operating room. So
Yeah.
either, getting into that a little bit, finding an OR nurse to talk to, because
Mhm.
it's a pretty, there are a lot of nurses down there.
Yeah.
And so I think that could be cool. Something just like that. I think getting a resident or getting a doctor in would be interesting, just to get them, their perspective.
Yeah, that would be.
Christopher's making quite a face right now.
His eyes are like bulging out of his head.
But just the kind of, little niche things. But
Honestly,
I like
it would
what you guys
probably
are doing.
be the doctor you work for.
She'd probably do it.
I know. She is like really cool.
Does she listen to our podcast?
She probably does it.
I told her, she asked what I was doing this weekend.
Oh,
I said,
did she?
well, Christopher has a podcast, and I'm going to be on it. I said,
So she might listen to this episode.
No, yeah. So you need to plug this episode.
All right, I'll tell her she's next.
Strap up.
We've got our eyes on you.
Oh man. Wow. Okay.
We love that idea though.
Yeah.
Yeah.
Overall, I do. I think you guys are doing great, and I like the podcast. I'm not a nurse. I've never been a nurse, but it still is interesting, and it still is relatable. So I think, continuing to expand upon kind of the things that you guys know really well, and then diving a little bit further away from stuff. I'm sure you could, get a school nurse in here.
Yeah.
Okay, maybe not that.
Oh
far.
yeah. I mean, I could.
And then we can always have you back.
I'm happy to come back.
It'd be fun.
Season 4? Question mark.
Season 4. Wow. So we'll wait a whole season.
Okay, season 3.
Yeah, you're like season 3. Yes.
I mean, we can't.
I didn't want to presume, but
who knows? Well, yeah, I think that's it. So, is there anything that you're like wanting to say, or do you want to plug your social media accounts?
No, I don't want to plug my.
Like, absolutely not.
One of the big things that I think that I've noticed that nurses struggle with, especially like it's mostly new nurses, but in general, it's just, and I think you guys talked about it on the last episode, 2 episodes ago, is like the critical thinking aspect to it. An order comes in, sure, it's an order you need to, but think about it for a second. It is a team. Everyone's heard the Swiss cheese model.
Mm-hmm.
If an order comes in that seems crazy, question it.
Yeah.
Ask a question.
If a patient is not doing well, but there's no, order that says to do something about it, take the initiative, escalate it, talk to your team. It's, you got a whole hospital full of resources. Reach out to somebody.
Yeah.
We're talking about patients. We're talking about people's lives.
Ooh.
It's important stuff. It's not a clock in, clock out job.
Yeah.
There's a lot to it, but
Dang.
we're all here. We're all here to help.
Yeah.
That's good.
No, I love that. That was a great way to end it.
Yeah.
A solid piece of advice to our up and coming nurses out there.
For sure. And for those that might think they know everything, I mean, like
it's a good reminder.
Yeah, so it's a good reminder to be like, it's okay to not know.
Mm-hmm.
Yeah. All right. Class dismissed. That's a wrap for today's session of Nursing Life 101.
Huge thanks to our guest Daniel for joining us and keeping it real about teamwork, growth, and respect in healthcare.
Thanks so much for having me.
Yeah.
I can't wait to come back for season 3.
Yeah. Well, hey, I'm okay with that.
Let me know. You have my number.
I do. Quite literally. We hope this episode reminded you and everyone that collaboration is what makes healthcare work.
You can find us on Twitter/X at NurseLife101. That's life with a Y, LYFE. Facebook at Nursing Life 101 or Instagram at nursing_life_101.
Don't forget to subscribe, share, and leave a review. Tag us if you've got a story about teamwork that made a difference.
Until next time, take care of yourselves, take care of your patients, and keep showing up for your team.
Thank you so much.
Thanks, guys.